this episode, I interviewed Dr Mars Skae about childhood obesity. If you enjoy these podcasts, please hit the like and subscribe buttons. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Dr. Mars Skae about childhood obesity. Mars is a consultant pediatric endocrinologist and the winner of the coveted Churchill Fellowship, which took her to America to immerse herself more in the subject of excess weight in children. She now runs a childhood obesity clinic. She is also a fantastic colleague. I am so pleased to have her on the show today. Mars, welcome. Thank you so much for agreeing to be interviewed today.
Thanks, Gail, for having me. It's a delight and long time in coming.
True. So, Mars, I find it really interesting to find out why distinguished colleagues like yourself chose the particular area of medicine in which they end up working. So, can you share with us what made you choose to work in the field of childhood obesity?
So that's a great question, Gail, because I didn't actually choose to work in childhood obesity. In fact, when I started doing work in it, childhood obesity wasn't even classed as a disease. The WHO hadn't even done that. And what really got me involved in it was my mentor at the time, Dr. Catherine Hall, had a research study looking at the use of metformin in children who were overweight and obese. And when the study came to an end, we had nowhere to send these children. And so we had to think about whether we kept seeing these individuals to try and help them. And if we did, then how we did that effectively. So we kind of dug deep as a team. And as I met with some of these children and their families, I realized that it was a much wider issue. It wasn't just a medical thing. I say that childhood obesity is a bio-socioeconomic condition. It's something I enjoy because it's multifaceted. There are lots of issues that cause it, but also it gives you lots of different opportunities to help individuals with that problem. And so I started knocking on doors like Manchester City Council to see if we could work together in partnership, because it's, again, not something that just is tackled within the hospital or by doctors. Yeah. You need a whole host of people working together to deal with this issue and help people onto a journey to sort of recover a healthy lifestyle and weight. I just pause there because I just want to say something around the terminology of childhood obesity. I don't use that term anymore. Obesity is quite a stigmatized word, and lots of people who actually suffer from the condition really find it difficult to deal with that word. So I use an unhealthy weight, and that's because unhealthy weight is a spectrum. I see individuals who are on the unhealthy spectrum of underweight, as well as individuals on the spectrum of overweight, unhealthy overweight. So that's kind of the terminology we try and use now, because we want people really to focus in on their health and how that affects them. So to cut a long story short, it was through the work of my mentor, Dr. Catherine Hall, who's now no longer with us. It kind of spurred me into this area, and that's how I got into it.
Okay, thank you. That's really, really impressive and inspiring, actually, that story. So, Mars, as you know, this podcast is aimed at educating patients. And for that reason, we try to avoid medical terminology as much as possible so that it remains as accessible as possible to as wide an audience as possible. So let's start with the very basics. What exactly is unhealthy overweight in children? And is there a definition? Are there different stages or grades? You alluded to that before.
Yeah. So the way we look at unhealthy weight in children is we look, because children are not like adults; they're growing,
Yeah.
and in adults we look at what's known as body mass index, which is a ratio, a calculation of ratio to height in an individual. And based on that, you are then categorized into whether you are overweight or in the obese category. In children, because they're growing, that is a dynamic value. And so we actually plot children on what we call centiles. That means we look at the overall population, and that's mixed ethnicities and children of various heights and sizes. And then we plot them as averages on charts. And then what we do is we take those values and we look at those that are really above the mean, which is where 50% of the population sits. So obesity, and I'm using that term in the medical sense of the word, is sort of categorized as those who are on the 95th centile and above. That means if you took 100 children who were exactly the same age and those same proportions in terms of height to weight ratios, it would be those who are the top 5 and above in that 100 cohort. And that's where obesity becomes a concern, or you categorize obesity. And unlike with adults, we also refer to the term severe obesity. And those individuals who are 20% above where I've just mentioned, those are classed as those who are severely obese. And that's where we really run into problems, because we start seeing health implications in those individuals as well.
Okay. And so I always discuss in all my podcasts about risk factors, because there are risk factors for, most of all conditions. And some risk factors are modifiable by lifestyle, for example, or medication, or whatever the case may be. Some are genetic and are therefore more difficult or impossible to modify. So can you talk a little bit about the risk factors for childhood obesity? Is it genetic? And is there anything that carers, parents, those who take care of these children can do to decrease their risk of becoming obese?
Okay. So the way I look at an individual who comes through my clinic is the first thing I look at is their I do consider genetic factors, because a lot of children come from families that are have a number of individuals in that family who are overweight. And what we do is we start off first by looking at what I would class as simple factors. So one obvious risk factor is an unhealthy relationship or an unhealthy lifestyle with food. So we first look at risk factors like, what sorts of foods are a family consuming? Are they really high calorie dense foods? Here in the West, we particularly live off processed foods. We live off foods that are highly, have lots of sugar or fat in, and these are caloric dense foods. And so that is a risk factor when you're eating foods like that. If you're eating and snacking throughout the day, that is another risk factor around food. And the other thing is eating late into the night. So lots of individuals now, particularly in the teenage cohort, they stay up late, they might be gaming, they're snacking through the night, and those are all risk factors for gaining weight. The second simple thing we look at is the lifestyle around physical activity a risk factor? So are you doing enough of physical activity? We guarantee ourselves with every generation a more sedentary lifestyle. So children used to walk to school.
Yeah.
Then it became they took, they cycled, and then they took buses, then they took cars. Now even cycling, you've got e-bikes, so you don't even put in the effort when you're cycling. And then we've moved towards screen play. So where children used to play outside or play games, they are now playing with each other, but on a screen. And so we're guaranteeing our children more sedentary lifestyles as they grow up. So those are the two simple things we look at. And then we look at genetic factors because there are cardinal features that would fit with what we call monogenic, so single gene changes that cause obesity. Now, those cardinal features are if someone is born and they become significantly obese under the age of 5 years. And that's because there's a clear genetic cause for abnormal energy expenditure and absorption in that individual and how they process energy. And the other thing that's quite cardinal is this inability to feel full. So my patients who have got genetic monogenic causes of obesity can eat an entire plate of food, and 2 minutes later they'll eat a whole other plate of food. They cannot feel full. And then there are sort of genetic causes which are what we call polygenic. So they're more in the background, in the population genes. So you may have families with things like FTO gene changes, but what I tell all my patients is that these genetic problems have always been there. They have been there for the last 100 years, 120 years. I mean, if we look at interesting, art, Victorian art paintings and things like that, you will see individuals who have been painted with these conditions. So what's changed? Because it can't be that the incidence of these genetic changes are going up so significantly that entire populations are becoming more obese. It's going to be down to the lifestyle changes that are driving this forward. And then there are the few individuals that genuinely have genetic problems that cause these risk factors. The other really important thing I just want to flag is that we also look at family history because we find this in South Asian families. We find in America, you would find this in the Hispanic populations, that when I said earlier, those who are in the severe obese category are the ones that tend to run into health problems. Yeah. What we're starting to find in Manchester, where I'm based, is that in those individuals who are for example, from South Asian families, that threshold falls. So they start running into complications and metabolic health complications at a lower weight than their Caucasian peers. And so we're starting to think about those populations as well, and those children and how we screen them as well.
Okay. And is there, about these genetic, the single gene ones, are there tests available to check? Is that routinely done? Because that would be really interesting, because I think a lot of families, a lot of parents are unsure of, whether it makes a difference in outcomes. We'll discuss a bit later, but if they wanted to know whether this gene was present, is that available?
So it's not available as a standard routine test. We now have the ability in the last few years to do a panel of genes and looking for these specific gene causes. We tend not to test individuals unless they have two of the cardinal markers that I mentioned. Right. So those with what we call hyperphagia, so they have this extreme desire to eat consistently. Individuals who start with a problem under the age of 5, more commonly, are the ones that we would get a positive hit in. And when I say positive hit, that means a positive result.
Yeah.
And the third thing that sometimes also flags is if they have learning difficulties. So they have problems with their development. Not always, but in a good few. So we would select out those that we would do gene tests in. Out of all of those with genetic changes, and I'm talking, we're talking needle in the haystack numbers here.
Yeah.
We are up until a couple of years ago, we only could treat one of those genetic problems. So we could only treat leptin deficiency. And fortunately, we now can treat a number of other conditions on a different genetic pathway called the MC4R pathway. We are able to trial a particular treatment in some of those children, but these treatments are currently in the research stages. So some of them, one of them has gone online in the US, and we're still waiting for that to come to Europe and the UK. But again, it only treats a small proportion of individuals, even with those genetic conditions.
And do you see many children who have other medical conditions that result in childhood obesity, if perhaps they're not well controlled, if they're poorly controlled, or just as a feature of another medical condition, for example, a hormonal disorder?
Yeah. So what I didn't talk about is what we screen for. So obviously my day job is as an endocrinologist, which is a hormone doctor, and two of the common causes of putting on lots of weight are an underactive thyroid gland. And so as a routine in our screening, we always test that. And the second thing is a much rarer condition called Cushing's disease. And that's when your body produces excessive amounts of steroids on its own. We do look to screen particular individuals. Again, we pick out those factors that might point towards that condition, and then we would screen for that. The other thing that I didn't mention is that we do have children who have got who are on treatments for other conditions. So, for example, you might be on steroids for another condition, whether that's inhaled steroids for asthma, or even steroids for treating juvenile rheumatoid arthritis. And those medications can sometimes lead to you becoming overweight or obese. And so we see patients with that as well. And then the last cohort that maybe I didn't quite touch on, but that's coming back to the genes, is that we know that some children are born with what we call syndromes. So, for example, one of the commonest syndromes that we know about is Down syndrome in children. And those individuals are at risk of putting on extra weight. And that's just part of the condition itself. And so what we try and do now is we try and tell pediatricians to be looking out for that much earlier on, because if you don't, then that becomes a problem later on, which was never addressed at the beginning.
Thank you very much. Really clear. So in terms of prevention, as opposed to treatment, in terms of prevention, advice to carers or parents, what advice would you give to aid in prevention? So diet, I guess you mentioned, moving more exercise, more time spent outdoors. Is there anything else? Well, that's pretty much it.
So, what we find is, and this is becoming a trend in even adult obesity, is that not one size fits all. What we're trying very hard is we have some basic principles that we share with all our patients, but we try and tailor things for the individual at hand. So, for example, if there is absolutely no point me telling a 16-year-old girl who absolutely hates to have breakfast, I need you to eat 3 meals a day, but small portions or something like that. It just won't work. So what I would do is go, well, okay, you don't like eating breakfast. When do you do? Which are your main meals? And what I would then do is say, okay, well, let's look at, because you're 16 and a bit older, let's look at time restricted eating. And look at windows of fasting windows to see if she could maybe eat dinner at a particular time, miss her breakfast, which I know my dietitian might not, that's not something we would standardly advise, but we try and work with individuals to try and make it something that's a sustainable change for them. In terms of exercise, you really need to be doing aerobic exercise because we have teenage boys who will go to the gym and they want to lift weights because they want to look good, and that's not what this is about. And it's about getting you cardio metabolically healthy. So that means getting your muscles, your heart, and everything else in a good working order, such that you are burning energy on a regular basis. So we advise aerobic exercise, but again, not everybody. So one of the huge things that we noted from an audit of our patients was that 40% of the children who came to our clinic struggled from one aspect of mobility. So trying to tell somebody to go out there and do lots of exercise suddenly isn't going to work.
No.
And so we actually try and tailor what we're advising them to do a lot. So those are kind of things we would do. And then the other things we would say, and this is a really important factor, is how does the family engage with that individual? Very often we have a scenario where an individual or a child is brought into our clinic and everybody's pointing fingers at that individual going, they're doing this and they're doing that and they're not doing this. And what we are trying to do is address entire families together. When we look at an individual, so take, for example, a 3-child family, and one individual has got a weight problem. It is not fair to expect this individual to not eat foods that their other siblings are eating that are unhealthy. So what we advise families to do is go and do a cupboard cleanse, okay? And the whole family gets behind that individual to try and change the entire eating habits and the lifestyle of that entire family, so that families are going out and doing park runs together, and that sort of thing. So I know I'm laboring a few points, but these are sustainable changes, not yo-yo dieting, not, one size fits all. We try and work with entire families to see what works best for them.
Okay. And at what age, so you mentioned about the cardinal features, at what age does it usually start to become a problem? At what age, because there's a concept of having baby fat, at what age do you say, oh, hang on a minute, I think there may be an issue here? What's the common age that you see children for it to start, for it to be a problem, to be an issue?
So the youngest child I've ever seen, and that was a child who I actually made a diagnosis of a monogenic cause of obesity in, was a young child who was 18 months of age. So, those genetic problems, you can pick them up pretty early.
Yeah.
The vast majority of individuals or children coming into the clinic, we would say wait until after the age of 2, and that's for 2 reasons. One is, under the age of 2, you have variation in weaning onto solids, and so often you have this peak where toddlers become really chubby, and that's because they might be still having lots of milk and getting weaned onto solids, and they're still not mobile. So everything gets sort of turned into toddler puppy fat, and but once they're mobile, after the age of 2, and they're running around and they're fully on solids, if you notice a problem at that time point, then that's already worth considering. And usually children will have their health visitor check at the age of 2, and that's when the early years are picked up. The vast majority that come into our clinic outside of that group are those in primary school, and that's because of the National Child Measurement Program. So they are measured in reception and they're measured in year 6. And that often triggers a potential worry for a parent. It shouldn't really trigger worry, but it may alert a parent to thinking, actually, maybe that I might need to do something for my child at this time point. And so in the primary years, that's a time point when they come to us. And then we have the teenagers, but that is usually a female cohort, and that will be because they might have irregular periods or not be having their periods, and that triggers a concern for them as well.
Okay, thank you. And Mars, you've dedicated a lot of your time and a lot of your energy to this issue, but why is it important? What are the risks if it is left unchecked and if nothing is done about it?
So I'm really passionate about this because we know from population studies that over 50% of obese children become obese adults, and we know from the NHANES study, which is a large US cohort study, that in those adults you would knock off at least 10 years of their lifespan due to complications from obesity. That is, that 10 years is an entire decade of a person's life. Yeah. And what is really concerning is for many years, when I first started dealing with obesity, the newspaper headlines were that, there were concerns that type 2 diabetes was going to become an issue in children. Yeah. And then it never really happened. And then people thought, doctors were scaremongering. But the truth is there was a lag for some reason. We don't really understand why that lag was there. But type 2 diabetes is becoming exponentially, it is increasing exponentially per annum in the UK at the moment in children. And the other reason I'm really passionate about this is because, as suspected, research studies are starting to show us that we can almost classify type 2 diabetes in children differently to type 2 diabetes in adults because it is a much more aggressive disease. Children develop complications at a much quicker rate with type 2 diabetes than adults do. So if you're talking about, a 50-year-old getting type 2 diabetes, and then they're getting high blood pressure and risk of heart problems and things like that when they're 70, we are talking about children who are 15 to 18, and you give them 10 years, and so by the time they're 30, when they in the prime of their lives, going to be having complications, we want to prevent this. And that's why I'm really passionate about this, is because this is a disease we can prevent and we can make change on. So that's why we need to educate people about it.
Okay. And I'm always also interested in the patient journey. So say I had a child and maybe they had the weight and height measurement in school, and I was advised maybe by the school nurse to take the child along to the GP or was referred to a clinic. What investigations are likely to be performed? What can parents, carers, and the children expect to happen next?
Okay, so the first port of call is your GP, and your GP can easily at least screen off two of those two things for you with your child. A GP is more than able to do a thyroid function test to make sure that your child doesn't have autoimmune hypothyroidism or an underactive thyroid, because that is easily treatable. And the second test that a GP could do is to check a glucose level, or what we call a hemoglobin A1C, which looks at average blood sugars over a longer period of time. So those are two things that your GP can easily do. And the other thing that your GP could do is check your child's blood pressure as well. If your GP is concerned, the next tier of individuals that you should see is a pediatrician, a general pediatrician. And that's because, we are talking about several thousand individuals just in the Greater Manchester area, children with obesity. And, there's one of me and thousands of them. And so what I've suggested to my colleagues is that we funnel in, the way we funnel people into the specialty clinics is by tackling what we can as prevention, what we can in community, and then we sort of come down into general pediatrics. And within general pediatrics, I expect if a pediatrician is concerned about particular features, then they should be able to provide lifestyle advice. They should be able to look at an individual and also co-consult us at this point. And they should be able to carry out tests, including looking at maybe liver function, looking at your blood fat levels, so cholesterol, which is what is one of those common levels, and also triglycerides, and looking at your general health. By the time an individual comes to us, they may or may not have had what we call an oral glucose tolerance test. And what that is, and pregnant women often have them, is that you have blood sugar test, and then you have a sugary drink, and you measure sugar afterwards to see how your body's processing that sugar. And we also look at insulin levels as well at that stage. By the time an individual sees me, they need to have a proven metabolic problem in one of those areas. That way I know exactly what I need to be looking out for, what I need to tailor, and what medication I need to provide for them, in addition to all the lifestyle changes that they should have already started putting in place by that time point. So it's kind of a stratified approach, but I think it's the right approach because it enables people to look at the obvious things that can be done and move into the more complex things after that.
Yeah, okay. And suppose I did have this child and these things happened and I was advised to take the child along to the GP. How urgently do you think that should be done? Do I think, well, I've got time on my hands, it's not urgent, or should I be quite quick about it? So what I'm asking is, does earlier recognition, does earlier management affect outcomes?
The absolute answer to that is yes. What we have found is just even within auditing our own cohort of children, the sooner you deal with an issue around unhealthy overweight, so we have looked at our cohorts because we have children from age of 3 up until 18, 16 now, and the under 10s are the group that we can actually reverse things really quite easily.
Okay.
Between 10 and 14, we can maybe get them to maintain. So they continue growing, but they maintain, and then perhaps go in a downward trajectory. And above 14 is the group we completely struggle with, because by then unhealthy lifestyle habits are inbred, and at that point children are learning autonomy.
Yeah.
They're voting with their feet.
Yeah.
And we know that the teenage brain really is quite different from the adult brain and a child's brain, because it is very much more triggered towards reward-seeking behaviors. And so children don't have, teenagers don't seem to have the ability to look at long-term outcomes, which adults can do, and actually younger children can do as well. And so we really like to get to children much earlier, because the sooner we can, the best outcomes we get.
Okay. And you spoke a bit earlier about advice around diet, advice around exercise. When patients come to you, so they're in your clinic, what discussions are held? What treatments are they offered? Apart from diet and exercise, are there any other treatments that are offered?
Yeah. So we would screen them metabolically, as I mentioned.
Yeah.
And if we find that they have what's known as insulin resistance, so that means their bodies are having to produce extra insulin in order to cope and keep blood sugars down. Our first line of treatment is something called metformin. Now, metformin is well known to type 2 diabetics because it's what's used in adults with type 2 diabetes, and it's a tablet. And we would use that for a period of a year to 24 months to see if we can reverse the insulin resistance, but also in that period of time get the individual through lifestyle changes to lose weight and metabolically change their composition. The second line from that would be the use of a treatment, and we still use something called Orlistat in our clinic, which is a fat blocker, or it prevents you from absorbing fat. Now, Orlistat went out of favor because of the side effects that people experience with that. What we found in our clinic is if you put somebody onto a low-fat diet and then put them on Orlistat, they don't get the side effects, but they get the weight loss. And also, we use Orlistat as a behavior modification thing, because sometimes people eat things and they don't realize that it's got fat in. Like, for example, I had a patient who came and said, I learned that this particular dish I made must have had fat, and I didn't think it had any fat, but I had symptoms with it, so I cut it out of my diet, and that patient actually did well. So Orlistat is a second line. And then we have newer treatments now called GLP-1 analogs. These have really been on the market in the last, I'd say, just before the pandemic. And some are still in research trial stages in children, but some are licensed in children or teenagers, older individuals. And we are using those. One of the common ones that adults can actually now potentially get from a pharmacist is called Saxenda, and we are starting to use that in teenagers. But it's only licensed for children above the age of 12, and you're only allowed to use it for a period of 2 years. We interestingly had a comparison discussion with some colleagues in one of our partner hospitals, and we found that actually all teams concluded when we were discussing it, that the people who did, or the children who did the best, were the ones that actually made the lifestyle changes. Because if you come into this thinking that this is a magic bullet and you're not prepared to do the hard work, then what you'll find is it just doesn't work. And that's what we're finding in some of our patient cohorts. Okay,
that's really interesting. Thank you. And what about the side effects of these treatments? Can you, I guess there's several, so there are going to be several, range of side effects, but are there any that you would like to mention in particular today that maybe are concerning?
Metformin, the biggest side effect really is it can give you a bit of a metallic taste in the mouth, but that usually wears off after a couple of weeks. But it can give you tummy, upsets and things like that. And usually what we just do is we change the preparation. We change it to a slow release or modified release preparation, and that usually sorts it out for most individuals. It can sometimes cause certain vitamin deficiencies, particularly in vitamin B.
Mm-hmm.
So we do advise people maybe to be on a multivitamin when they're on that. And if they notice that their hair may be falling quite a lot or something, then to get that checked. In terms of the other medications, orlistat, the side effects are purely really associated with the fat content of your food. So you get, loose stools if you eat fatty foods, and you get flatus and you feel bloated and things like that. But if you cut those foods out of your diet, then we don't see as much of those problems. With GLP-1 analogs, I'm still a bit cautious because they're newer drugs. We know that GLP-1 analogs can cause gut stasis, so they can cause quite severe constipation. A lot of the children who've been on them seem to experience quite bad nausea as well. And the other thing is that it can sometimes cause gallstones as well. So, we don't put patients on these treatments lightly.
Yeah.
We consider them, and we also monitor for side effects.
Yeah. And I guess when we put any patient on any treatment, we always weigh the risks versus the benefits. And as you mentioned, the risks of a lifetime of severe obesity are significant. So it's just about having that conversation.
Absolutely. Yeah.
Okay. And can you give us an idea about how successful these treatments are for weight loss?
So, what we found, and this is the honest truth, is that the success of treatments a lot of the time is directly associated with the level of motivation as well.
Yeah.
We found that when individuals are motivated, and it also correlates a lot with mental health as well. And I think that's a really important point that I want to put forward, is that a lot of the children that I've talked about the metabolic complications, but actually the two things that I didn't talk about is that what children experience first as complications of their overweight or unhealthy weight is mental health and low self-esteem first. And the second thing is also impact on mobility. So primary school children finding they don't get chosen for the school sport teams.
Yeah.
They can't keep up with their friends in the playground.
Yeah.
And things like that. But coming back to what I was saying, motivation is key. People who can make sustainable changes is key. And all we aim for. So I am not in the business of trying to change this is not about size. This is not about, whether you're in a size 8 dress or a size 14 dress. This is about health. And so all we are looking for is to improve someone's weight to the point that we reverse complications. Now, what is that number? That number is usually in the range of 5 to 10% of their weight that we're looking to drop. Now, in children are growing. So if they just keep their weight stable sometimes, because they're shooting up in terms of height, they're actually naturally slimming down.
Yeah.
So it is looking at all those factors and then trying to, we're trying to basically move them out of the unhealthy risk category. Is that 10 kilos in weight? It varies for every single child. And so we set the targets based on where they're starting from and where we think we need them to get to. And, often it's just halfway in between, but that's enough to do what's good for them and also just improve their quality of life. And that's what we're in the business of doing. We want to improve children's quality of life.
And are there any other, apart from personal motivation, are there any other factors that can influence success rates? Maybe external factors. So I guess family motivation, as you mentioned before, and family support, maybe psychology. Is there anything else in the mix that may help children and adolescents towards a more positive outcome?
So that takes me back quite a bit. There was a really interesting study in Australia a number of years ago, looking at two groups of children. So these two groups of children had the same lifestyle interventions. The only difference was that one group of children kind of had a social circle transplant, in that they moved that group of children into a sort of social circle when all the children were really active and doing lots of things. And when they looked at the results of that study, what they found was that in both groups, they both lost, but one group regained and one group didn't.
Interesting.
As much. And that was the group who had the social circle, the buddies who kept them on track. And we found this in NIHR studies with adult men as well. So there have been studies, where Premier League football clubs have taken on board groups of men and done community-based football with them. And even when the studies have ended, these groups of men have stayed together, keeping healthy and, kept it going for longer. So what I really ask some of the kids to do is, have they got buddies? Have they got, especially the teenagers, have you got a mate to go to the gym with? Someone who will keep you inspired, because if you can do that, you can sustain that change for much longer. So whether it's your family who act as buddies, but for teenagers, sometimes it's your mates.
Yeah.
That's what you want. You want to be surrounded by people who are going to give you that encouragement, and they are going to keep you doing the right things for the rest of your life, really.
Yeah, thank you. Really clear answer. So thank you, Mars, for those clear and detailed answers to my questions. As you know, I ask members of the public, patients, to submit questions before my podcasts in order that I can ask them on their behalf. Are you happy to answer a few questions that have been submitted?
Absolutely.
Fantastic.
If I can.
So I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of the history, clinical findings, investigation results. Due to time constraints as well, I've summarized the questions in such a way that I think retains what is being asked. Therefore, these answers should only be used as a guide, and individualized care should always be sought from one's own doctor. Okay, so the first question is, I would like to ask if there are any recommendations for children on long-term steroids for asthma who have developed Cushingoid features and gynecomastia. So can you just explain those terms for people who don't understand? Why doesn't long-term effect of steroids on children's bodies seem to alert the GPs in the UK? So 2 questions, any recommendations, and 2, why doesn't it seem to alert the GPs?
Okay. So I'll answer the second bit first. I'm obviously no longer a general pediatrician, and I'm not a respiratory physician, but I know that the symptoms of asthma, severe asthma and brittle asthma, is very frightening for some individuals.
Yeah.
And the priority for a lot of GPs is that we want that disease or that issue controlled, so that a child is not at risk of ending up on a high dependency unit or that sort of thing. Having said that, I think it is important that people are aware. I think there is this notion that inhaled steroids are not like tablet steroids or intravenous steroids, so they're not going to be as harmful. But actually, individuals can absorb those steroids really quite well, and it can have those effects. So what I would say is that if you notice that your child is perhaps putting on rapid weight on those inhaled steroids, then it's a conversation to have with your GP, and or your respiratory pediatrician, because there are newer therapies that are out there. And I know that a number of my patients who are have brittle asthma have been weaned off the steroids, or weaned down on their steroids with additional medications added in to help their disease control. So I don't think GPs choose to ignore it. I think it's just that asthma can be a frightening disease for some. Coming back to your first question, which was, well, what do we do then? I think, to try and push the boat out and try and wean steroids is always a good thing. And, certain times of year might be better for certain individuals. Some people are better in the summer, some people are better in the winter. And it's just a case of trying. And, you can try and step back and work with your pediatrician or your respiratory physician or GP practice to do that. And the thing about it is that once you do eventually get off them with a healthy lifestyle, things should normalize in terms of your weight. And so that's the positive to take from that, not to worry that it's going to be a permanent change. And it's a dynamic situation. So, just keep trying if you can.
Okay, thank you. Thank you for that really clear answer. And just to say that Cushingoid features are features of Cushing's syndrome, which are a rounded face, central fat deposition. Gynecomastia is
it's basically developing breast tissue in a male.
Correct.
Yeah. But those are the things that yes, sorry, I didn't quite answer that question.
But and there are, what you said is really, really valuable, because people may not realize that they are reversible. And that's the take-home message there. Don't worry too much. Deal with the problem that's the bigger problem now, and in due course, deal with the secondary problem, which is then reversible. So that's a brilliant answer. Thank you very much. Okay, so second question is there any relation between the gut microbiome and childhood obesity? Second to that, also, since breastfeeding plays a role in influencing gut microbiome, is this part of the relationship between decreased obesity and breastfeeding? And is there indeed a relationship between decreased childhood obesity in the breastfed? So 3 questions for the price of 1. So take them one by one. I'll give them back to you. I'll give them back to you one by one. So is there a relationship between breastfeeding and a lower risk of childhood obesity is the first question.
Okay. So yes, there is a risk, there is a link between breastfeeding and a reduced risk of childhood obesity. We have traditionally thought that is because, you self-regulate better on breastfeeding, and you don't force feed an individual extra calories in terms of milk. Also, the body adapts in terms of the quality of the milk that they're producing, whether it's got more protein versus more fat in it as a child gets older. So we've traditionally thought that those issues or those reasons are the key reasons for why breastfeeding tends to reduce the chance of childhood obesity. And also bottle-fed children have traditionally ended up being weaned earlier. And they've then continued on bottled milk with the weaning, which I meant, solids, weaning onto solids, which I mentioned, which has compounded issues. The question about the gut microbiome is a really interesting one. So I'm not an expert in that. It's a very new field. But what we do kind of know is that the gut microbiome is being established over the first 3 years of a child's life. So you kind of start off being born with not very much, and then it gets established over the first 3 years. And so we know that breast milk does confer healthy, or should confer healthy, gut microbiota to a child, and that should get them sort of metabolizing food better. We also, now this is extrapolating studies. It doesn't necessarily mean that it's something, a finding in one is the cause of another.
Yeah.
But we also know from Scandinavian studies that children who have frequently been given antibiotics early in life tend to have a higher risk of obesity. Now, those studies were done with regards to antibiotics, and the thought that's evolved into the thinking, have these antibiotics knocked off all their good gut microbiota, which is predisposed to obesity. Is it causal? I can't categorically say yes, but logically, there seems to be a trend. So we need a lot more to say for definite this is the case, but it's certainly all linked together, possibly as a sort of, organic system that works together.
Yeah. Great, thank you. Next question. What 3 factors do you think can have the greatest impact on reducing the incidence of obesity in children? So what 3 factors can have the greatest impact?
From what I see in my clinic, I think what you're eating is going to have a huge impact. How you expend energy in terms of physical activity is going to have a huge impact. And the third factor, I think, actually, and I say this with a little bit of caution, but I think a really healthy environment is key to success around weight management. We have a lot of children who don't even sit down at a table together as a family and eat food. And that's one of the first things we say. Are you eating together? Are you not eating in front of a television?
Yeah.
It's healthy habits as a family. Are you getting out and playing games together? Are you, encouraging each other? And then, that improves mental health. And when you improve mental health in a child, they are more willing to try new things. So I think for me, I look at it a bit more holistically. It's not just eat less, do more, but it's tailoring those things, but those certainly have a huge impact. And then I think it's really about lifestyle, and being a happy, healthy child is and their environment is key for me, at least.
And what about greater changes, say, on the level of societal change? What are your thoughts about that?
I think it's society is a really tricky one, isn't it? Because we've been going on so long. I've supported campaigns around food advertising before the watershed period. We know that what children see in food adverts and things like that are all going to, you go past a bus and you're seeing, a big burger as an advert and things. The other thing that's my real bugbear at the moment is the number of dessert bars that are on the rise. Everywhere, it seems to be the trend. Milkshakes, bubble tea, this sort of thing. And, how can we tell our children, you can't go in there, you can't do that? So retail and food industry, I think, really needs to be responsible around what they're doing. And it's important that we don't stigmatize people, but at the same time, we help them understand. So you know, when you walk into, I don't tell my children, well, I say my children, my patients, not to go into a fast food restaurant. What I do tell them is, if you go into the fast food restaurant, this is what I'd kind of ask you to do. Have a think about this. You have to give people ways of coping with society, and or societal factors, and the draw of them. The other thing is that the pendulum swings in opinion. So we have individuals who say, well, actually, we shouldn't be stigmatizing people, so we shouldn't do anything about this. You know, we should be enabling children to be happy the way they are. Well, that doesn't change their risk of type 2 diabetes.
Yeah.
So it's really important that we address issues in a truthful manner, but also we do it in the context of compassion, and we do it with the child at the center of it all, because we want them to have a good quality of life and a long life that's healthy.
Absolutely, yeah. Okay, so the next question is, we know that surgery is the most effective treatment for obesity in adults. Is surgery a viable option for children?
So yes, surgery is a viable option in children. It is a viable option in post-pubertal children. So it's important that I think surgery is an extreme. It's the extreme end of therapy for someone who is severely overweight, and it has significant complications in terms of the amount of stuff that you absorb after surgery. Gastric banding is not done in the younger cohorts. The operation of choice now is what we call a gastric sleeve. So what that is the stomach is basically stapled to kind of half its size. And, you know, I'm making that sound very simple. It's actually more complicated than that. What people used to do in the past was called a gastric bypass, and that's where you completely bypassed bits of the gut, and that led to lots of malabsorption problems, and still can do. But even with the gastric sleeve, you can have issues around absorption and anemia, which is, you know, low blood, red blood cell counts and things. So it's important that we reserve this for really the most severe cases, because it does have long-term implications. The second thing I'd say around surgery with children is, we know in adults that even with surgery, there is weight regain. So after 10 years of having a gastric surgical procedure, bariatric surgical procedure, you will weight regain somewhere in the region of close up to 50% of the weight you have lost. So you do have an overall loss, but you gain 50%. So if you do this procedure at the age of 15, at 25, that individual would have potentially regained 50% of that weight. And then what do you do? Because they're only 25. So, and they're going to have to monitor for long-term complications for the rest of their life. So my advice is that this should be reserved for those who have absolutely are at significant risk for health issues, but also those who are really not winning with other forms of therapy. The other thing in the adult world is that they are now demonstrating that very low calorie diets can reverse metabolic complications at an equivalent rate to bariatric surgery. So the reason people have opted for bariatric surgery is because it's so good at reversing type 2 diabetes and all the other complications that goes in metabolic health complications with obesity. But we are starting to see some of that in some of the newer therapies that are coming out. And we are starting to see some of that with really quite specifically tailored, very low calorie diets. So I would say, yes, it's an option, but you really don't want to be thinking about it until you've exhausted all other options or you're at significant risk of a health problem.
Okay, thank you. Okay, the next question is, why has childhood obesity skyrocketed over the past few years. Is it down to children spending hours in front of computers playing games? Should there be national guidance around screen time limits for children?
That's a great question. uh, could I? It would be absolutely fantastic if we could put, screen time limits for all children. I can't even do this on my own child, so I think realistically, it's going to be a difficult one. If I could, what I'd say is, if they like tech, go for active tech. So there was actually some demonstration that Pokemon Go helped children lose weight because they were having to go and chase these Pokemons outside, and they were walking miles trying to find these Pokemons. If your children like games, things like Just Dance, K-pop dance, the girls love that. Not all tech is bad, but it's how you use it. Do we need to put guidance? That I don't think the government can do anything about that. I think it's just being sensible as families about what is acceptable. We do know that 4 hours of I think it's something in the region of 4 hours of screen time increases your risk of obesity by 50% per day. So you've got to weigh that up. Why is the population getting more obese? I think I mentioned issues around having more access to high calorie dense foods, less activity, and like I said, genetic factors were there 50 years ago, 100 years ago, but the population is getting bigger. So it's got to be something that's changed in recent years. And those are the two big things, I think, that have changed.
Okay, thank you. And the last question from our listeners is that I have struggled with my weight all my life. I have been diagnosed with PCOS, so polycystic ovary syndrome, which I've done a podcast on, by the way, if anyone's interested. So I've been diagnosed with polycystic ovary syndrome and was prescribed metformin. My 13-year-old is also overweight, but her bloods do not suggest polycystic ovary syndrome. Can she have metformin to help her lose weight?
Okay. So what I'd say to that individual is they might not have all the features of the metabolic features of polycystic ovarian syndrome, which is high androgen levels, which are male-like hormones that you find in women. But they might have a high fasting insulin level. And that might not have been tested for, because that's not a standard test you would do for polycystic ovarian syndrome. Mm-hmm. And if they do have a high fasting insulin to glucose ratio, then it would be something that we would actually consider metformin treatment in. And that's because the insulin pathway is very much linked with appetite. It's very linked with how hormones regulate in terms of connecting up with your ovaries, which is why we're talking about polycystic ovarian syndrome. So yes, even in a 13-year-old, we may consider metformin treatment if they have evidence of a high or evidence of insulin resistance. So it's worth seeing a doctor about it to get that tested for specifically.
Great. Wonderful answer. Okay, so Mars, that's all the questions we've got submitted. However, I've got one more question, which is from me.
Oh.
You have managed many, many children with weight-related issues in your career thus far. Given the opportunity, what would you like to say to parents or carers and the children or adolescents themselves who are struggling with their weight?
what I'd like to say to absolutely anyone that's watching this podcast and any of my patients is that I think it's really important that your life isn't dominated by weight. We want you to have a happy and healthy long life. And so anything you do, you know, it's about making sure that we get you there. And we aren't about, you know, I wouldn't want people to define themselves by clothes sizes. I wouldn't want people to define themselves by the way they look. I would want people to define themselves by how they feel and the confidence and self-esteem they have. And for me, a big win in anybody is if we can get you to a place where you feel better about yourself. And I come back to a couple of my patients who, when I first met them, they couldn't make eye contact with me. There was a young lad who came in because he couldn't play basketball, and he really was so desperate to play basketball, and he couldn't make eye contact with me. When we helped him on his journey, which was really quite complicated, but we did finally get there. And it takes a lifelong, you know, none of this is easy. That's the other thing I want to say. What I ask people to do sounds easy on paper, but it is not easy by any means at all. And it's something that we're asking you to do for the rest of your life. So we want it to be something that's enjoyable, you know. Don't force yourself to, you know, make changes that makes you unhappy. It's got to make you happy as well. But this young lad, when we got him to the place he wanted to be in 2 years later, he was able to make eye contact. He joined a basketball team, and he was able to do the one thing that he wanted to do, which was play basketball. It wasn't about his clothes size, you know. That's what we're in the business of doing, is making people feel whole. And that is what I want for anybody who wants to embark on a healthy lifestyle change. It's about you becoming a whole person and being at the place where you want to be. Don't be moved by social media, please, because, you know, I had a young girl who came to me. She'd lost all this weight, and she said to me, Dr. Skae, but I watched a TikTok video that tells me that I need to lose 20 more kilos. And I was like, are you mad? You'd be underweight. You'd be in my other clinic, you know. So please turn off the TikTok now, you know. And those are the kind of conversations I have with some of my patients. But, you know, that's the thing. It's not about anybody else. It's about you and your family and the whole family. You know, I've had conversations. Sorry, I'm rambling on a bit, but it's important. You know, I've had parents who I've had to send the child out of the room and say to them, what are you doing? Because if you carry on the way you are and you don't make the changes yourselves, you won't be here for the rest of your child's life. One of you's got cardiac disease and one of you has had a stroke already, and you're in your 40s. So I really want you all as a family to stay together for a lot longer. So, you know, it's about whole families as well. And, you know, that's what we want. We want people to feel whole, happy, and healthy. And that's what this is about, really.
Thank you. Those stories are really wonderful, Mars. Really wonderful. So in closing, Mars, it just remains for me to thank you. Thank you so much for agreeing to join me today on the podcast. And thank you for supporting my efforts at educating patients and families. Thank you so much for the work you do, the countless hours you've spent and continue to spend in helping families and children and adolescents with weight issues. And I have to say, your passion is obvious and it is very inspiring. So keep doing all the good work you're doing. Thank you so much for joining me today, Mars.
Thanks, Gail. It's been a real pleasure, and I hope somebody watches this and doesn't think I'm a complete loony bin, but actually, finds this helpful. So thanks for the opportunity.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.